I'm Carrie Rimmel, Director of Stroke, lecture on emergency stroke. So the first question when the patient hits the door in the emergency department is it a stroke? There are many mimics. And so a person can have a complex migraine. Certainly that's not high on our list. We're going to first think of stroke, but they could have extremes in metabolics. They could have extremely high or low blood sugars. They could have other metabolic problems. Even hypothyroidism can present with a focal deficit, a sudden focal deficit. So that's something to consider, but you're going to work them up when they come in with a sudden onset of a focal neurological change. I'm going to think about stroke first and work them up. Focal seizure, what looks like a hypodensity but consistent with a tumor. CNS infections can present as mimics, or there also can be vasculitis and can lead to strokes. And then, of course, intoxication. The critical points that we always tell people, we need to know the time of onset. But we've changed the wording now. We don't say time of onset because so many mistakes are made if you say what was the time of onset. Mistakes are made unless we say, when was the patient last seen normal? The time frame matters because the only FDA-approved treatment, IV TPA, is given in a specific time frame from what we believe is the onset time or last seen normal. We also need to know, did they have a prior stroke, and if so, when? Because one of the exclusions for IV thrombolytic is a stroke within the last 3 months. Why? Because those people tend to bleed. They will bleed with IV TPA. And residuals. What were their residuals? Oh, well, the person presents with right-sided weakness and aphasia. Yes, he had a stroke 6 months ago, and he still has residual right-sided weakness and aphasia, but we called 911 because it was worse. So is it really a new stroke, or is this a worsening of the old stroke? Is there something else going on with that patient? What else could be going on with that patient? They get worse if there's a medical illness like an MI, like an infection, UTI. What if the person had a cortical stroke and they had a complex partial seizure? With no convulsion in the plegic side, but they had a worsening of their symptoms. So you really want to know when that stroke was and what the residuals were. And then also, what are their home medications? Are they on anticoagulation? Warfarin or one of the newer anticoagulants? Are they on antiplatelets? What are the other medicines? On arrival, of course, we're going to do all the usuals. A CT of the head is done very quickly, and in fact, by Joint Commission standards, you are expected in a stroke center. You have to prove that you have been able to get those CAT scans of the brain within 25 minutes of the patient hitting the door. CTA of the head and neck. That is not a requirement for IV TPA, please believe me, but in stroke centers, typically what you'll get is a CT-CTA. It's just an extra few minutes, and we can look at the vessels from the arch up. The labs have to be drawn and back within 45 minutes of the patient hitting the door. We keep all of these times, and Joint Commission reviews every time we have. I want to say something about the tox screen. So the oldest person that I had a positive cocaine on was 83, but he had just started using cocaine, had a stroke. Cocaine can cause a vasculitis, it can cause vasoconstriction, as you know. 12 lead EKG, X-ray, chest X-ray, and we don't give D5W, just normal saline. NIH stroke scale, it's a standard. We use it in all of the clinical trials, and we get one on admission and discharge. You have to be certified annually, and it looks at level of consciousness, looks at visual fields and gaze palsies or extraocular movements, looks at facial weakness or strength, and then arm and leg strength, sensory functions. It looks for dysmetria or ataxia. It looks at language functions, also speech, that is motor speech like dysarthria, and extinction, so sensory extinction, visual extinction. This just shows you the Boston aphasia diagnostic battery. These aspects, they're just portions of that aphasia battery. These are used in standard. That's just part of the test. Now, acutely, this is acute ischemic stroke, CAT scan. Does it show any hemorrhage? No. And a TIA patient, CAT scan would be the same, acutely. Acutely with a stroke, ischemic stroke, you're not going to see the ischemia. Not going to see it. So there's not going to be a hypodensity acutely. It takes hours for a CAT scan to show ischemia. After 3 days, there's your hypodensity. Had a left MCA occlusion. TIA and stroke are really the same condition and should be aggressively treated, aggressively worked up, the same. Just because a person had a 20 or 30 or 40-minute spell of a focal neurological deficit and then they're back to normal does not mean that they shouldn't get the exact workup as a person with a stroke. There's a new definition for TIA. We no longer say that it's a stroke-like event that lasts less than 24 hours. The new definition is it's a stroke-like event that resolves usually within an hour and there is no infarct. About half of the patients that have a clinical TIA that lasts longer than 30 minutes actually have a stroke on MRI. The big deal here in therapy for stroke is saving the penumbra. I mean, I'm not going to be able to do anything about the core stroke, but usually in the acute setting, there's a penumbra, salvageable tissue. So that's really what we're going after. In all of the treatments, we're going after the penumbra. Is there a mismatch? So on MRI, we have diffusion-weighted imaging, you've all seen it, lights up for ischemic stroke, and perfusion deficit. And so there can be a diffusion-perfusion mismatch. And that area that is the mismatch is your penumbra, or salvageable tissue. And what do we have available? We have IV TPA, 0 to 3 hours, 3 to 4.5 hour window, and then endovascular recanalization. The exclusionary criteria are long. I'll highlight some. Stroke symptom onset less than 3 hours, clinical diagnosis that looks like a stroke. The one that I want to point out on this slide, one of them is clearing spontaneously, rapidly improving. Tell me about the exam. Came in, was mute, plegic, facial droop, eyes deviated to the left, and now the patient is mumbling and can sort of lift against gravity. Well, if everything else fits the criteria, you're going to get it. That's a measurable deficit. So you have to say improving to what? If it's improving to an NIH of 1 or 2 and it's really minor, like a sensory type of problem, then they're probably okay. But any cortical sign trumps it. I mean, if they have a 1 or 2 and it's aphasia, that's critical, and that trumps the number. We want to avoid using excuses not to give. Look at all of these exclusionary criteria. I'll point out a couple. If the person's blood pressure is greater than 185 over 110, we've changed things. So in the original, they said you cannot treat blood pressure aggressively. Now, every stroke center in the country puts the person on a Cardine drip or a nicardipine drip or gives them labetalol. And so we try to get the pressure down below 185 over 110. But if you can't, then you can't give IV TPA. The blood pressure is critical because there's a big mark where there's a larger hemorrhagic transformation or hemorrhage with TPA in the high blood pressure ranges. The other I wanted to point out was the INR. So in the 0 to 3 hour window, you can give IV TPA to a person on warfarin as long as their INR is not greater than 1.7. However, if they're on any of the newer anticoagulants, you can't give it. If they're on it, you're not checking levels, so you can't give it. In the NINS trial, after getting IV TPA, there's a 32% relative benefit compared to placebo. Symptomatic hemorrhage rate across studies is around 6 to 7%. Symptomatic hemorrhage rate with TPA. The mortality is not significantly different between placebo and IV TPA. And then the benefit for function is improved no matter what the type of stroke. Even a small vessel stroke. The sooner you give drug, the better. Just remember that time is not on our side when it comes to stroke. We've got to be quick, because for every 1 minute of ischemia, you lose 1.9 million neurons. If an outside hospital gives the TPA, that's drip, and then ships it to a stroke center, so that's drip and ship. My point is, you don't ship and then drip. Why? Because of the loss of neurons on the way. But does it matter if we recanalize the vessel if we don't have improved function? So at 12 months after stroke, there was a significant difference between drug and placebo. The red line is improved. So on the Barthel, you can see a big difference. Barthel, you're familiar with it. It's activities of daily living. Can you feed yourself? Can you take care of yourself? So Barthel index is significantly improved at a year out after stroke for those that get TPA. Meta-analysis of 52 studies of thrombolysis with acute ischemic stroke shows about a 4-fold reduction in mortality and 4-fold increased chance of independence. And then just to let you know, you need, in a stroke center, you really need to be able to give the drug within an hour of the patient hitting the door. So you have to have all these pieces and parts in place, everything lined up. You'll see better outcomes if that is done. So there's a dose of 0.9 milligrams per kilogram. We give 10% as a bolus, and we drip the rest in over an hour. Patients go to the ICU at least for 24 hours. What about if the person is not a TPA or intervention case? So, of course, we do our stroke scales, we look at our vessel imaging, we get our labs. The guidelines still say don't treat blood pressure in an ischemic stroke until that blood pressure is greater than 220 over 120. And so that really is scary, but we're trying to protect the penumbra. If you're going to bring the pressure down acutely when you're taking care of the patient in the hyperacute stage on the first day, you want to use IV drips that can control, so you can give a target blood pressure. Individualized care is the key. Of course, treat blood sugars, fevers, infections aggressively. All three of these will cause the core stroke to enlarge. Just to let you know that there's a 3-fold increased risk for higher mortality in patients with hyperglycemia. If they're non-diabetic, and the diabetics, it's double the risk. The reason why we want to treat hyperglycemia in the acute stage, especially with TPA cases, is because there's more hemorrhagic conversion in TPA cases. If the sugars are high, outcomes are worse. You will get patients that change on you at the bedside. I mean, you'll see them, and then the nurse will call you 15 minutes later, and there's a big change, and they look like they're having a stroke. But you're not going to know whether it's ischemic or hemorrhagic by doing a neurological exam. So you have to go down the pathway. Very common is hypertensive hemorrhage. The most common sites for hypertensive hemorrhage are these. Basal ganglia, very common, thalamus, pons, cerebellum. If they have a bleed in the lobe, we're starting to think about other things than a hypertensive hemorrhage. If they come in with a bleed in a lobar hemorrhage and their blood pressure is very high, I don't just automatically knee-jerk say hypertensive hemorrhage. A person could bleed into a tumor. Older person, lobar hemorrhage, are they demented? Could be amyloid angiopathy. Or lobar hemorrhage, person with migraines, maybe it's some type of a vasculitis. What about blood pressure? We really don't know. Isn't that pitiful? But the guidelines say keep the systolic blood pressure under 160 in bleeds. And then we have protocols and hemorrhagic stroke orders.